On this slide is some excerpts from a statement by the American Association of Clinical Endocrinologists in 2012, establishing obesity as a disease and iterating some of the reasons for that. I'll just read some of this. It's a strong contention of ACE that the view of obesity as a behavioral decision is debunked by biomedical evidence. Obesity is a primary disease, and the full force of our medical knowledge should be brought to bear on the prevention and treatment. And it's an altered physiological and metabolic state with genetic, environmental, and behavioral determinants, which results in increased morbidity and mortality. Then a proposition was put forth to the American Medical Association, and they also declared obesity a disease 1 year later in 2013. It is a disease like any other chronic disease. This thing is set on automatic advancement of slides. Can that be taken off somehow? So it's a complex interaction between genes, biological factors, environment, and behavior. In the case of genes, we know from GWAS studies that there are over 100 obesity genes that have been identified, and these, can you fix this? And each one of these genes only explains a very small relative risk of the disease, so you really need to inherit and aggregate larger numbers of these genes to increase your risk of the disease. But these genes are interacting with each other, interacting with the biological factors, the in utero environment, gender, age, the environment, food availability, the built environment, socioeconomic status, and behavior, dietary and physical activity preferences in a way that leads to increased adiposity. It also meets the three criteria of a disease. One has characteristic signs or symptoms, and we use BMI for that purpose. Also involves an impairment in the normal functioning of some aspect of the body. I've listed two of those here. Dysregulation of satiety hormones and their interaction with the hypothalamus, driving increased caloric intake. Second example is adipose tissue dysfunction on a background of insulin resistance, which exacerbates insulin resistance and leads to progression of cardiometabolic disease. And finally, it results in harm or morbidity, and we know that it's responsible for a large number of cardiometabolic and biomechanical complications. So it meets these criteria for a disease, in particular the complications. I've kind of delineated the cardiometabolic nexus of diseases. Here, the dyslipidemia, hypertension, prediabetes, diabetes progressing to cardiovascular disease. All of these have insulin resistance as their underpinning. I put non-alcoholic fatty liver disease and polycystic ovary disease under this umbrella. They have metabolic syndrome as well. There's also the biomechanical complications. These are due to just carrying around an increased body mass over a number of years. Very important complications: sleep apnea, osteoarthritis, stress incontinence, dysmobility, and others such as depression, stigmatization, disordered eating, cancer, and gallbladder disease. And it's these complications that impair the health of the patient. These complications cause morbidity and mortality. So what do we do when we treat diseases in patients? We want to improve their health, right? So it's more than just losing X amount of pounds. To improve the health of the patient when we treat this disease, it's preventing or ameliorating these complications of the disease. If you think about it, this way of looking at obesity is consistent with its pathophysiology and its natural history. Like any chronic disease, diabetes, asthma, hypertension, as I said, there's an interaction between genes and environment that precipitate the disease, obesity. At this stage, it's uncomplicated. We're in a secondary prevention mode. Our goal is to prevent disease progression, of further gain in body weight, and to prevent the appearance of complications. But all patients with obesity are not the same. There's other genes, other perhaps overlapping subsets of genes that interact with environment that determine how severe the disease will be and whether the disease is associated with complications. So now we're in a tertiary treatment mode. We need to be more aggressive. We need to prevent further deterioration, and we need to treat these complications. So obesity is a disease in which disordered regulation of caloric intake results in high levels of adiposity, and in turn, these high levels of adiposity impair health via these weight-related complications. And this is kind of central in the ACE algorithm for medical care of patients with obesity and obesity treatment guidelines. I don't want to go through all the fine print here, but basically, as Dr. Gosh pointed out, the initial stage is diagnosis. There's two components to diagnosis. One is anthropometric, the BMI, and whether that BMI represents increased adiposity, perhaps the waist circumference, and the clinical component of the diagnosis, which is the presence and severity of weight-related complications. You then use this information to stage the patient, stage the severity of disease, and then that staging is used to determine the modality and intensity of treatment based on that disease stage, with a goal towards improving those complications. So the endpoint of therapy in a complication-centric approach is not to lose X amount of pounds, but to improve the health of the patient by reaching your target in terms of preventing and treating these complications. Again, this is from the ACE algorithm, the two components, the anthropometric and the clinical. Here's a list of complications that can be treated or ameliorated with weight loss therapy. And both of these are used to stage the disease, stage 0. If there's no complications, again, you're in a secondary treatment mode. Lifestyle therapy, structured lifestyle intervention may be appropriate here. But once you have complications, that's telling you that that degree of adiposity, whether it's a BMI of 22 or 25 or a BMI of 30, is sufficient to impair the health of the patient. Stage 1 if those complications are mild to moderate, stage 2 if they're severe, but then you really have to think about pharmacotherapy added on to lifestyle intervention, and in some patients referral for bariatric surgery. And if you think about it, there's a dose response in how much weight you need to lose to improve different complications. We know from the Look Ahead study that measures of glycemia, lipids, and blood pressure, you can get improvements with about 5% weight loss, but the more the better, up to and including greater than 15% weight loss, there's progressive improvements. We know that hepatic steatosis, you can get fat out of the liver by losing 5 to 10% body weight, but to address fibrosis and inflammation, you really need more than 10%. Measures of feeling and function, 5 to 10%, we can get improvements. Preventing the progression from prediabetes to diabetes, 10% weight loss is maximally effective. When you want to improve sleep apnea, you really need 10% or more weight loss to get predictable improvements in the apnea-hypopnea index. And then the highest amount of weight loss is needed to reduce cardiovascular events, which have been shown with bariatric surgery. So the goal here is to achieve sufficient weight loss to improve health by preventing or treating these complications. This is reflected, I think, in the consensus statement for the diagnosis of obesity, abdominal obesity and metabolic syndrome. It was published in the Journal of the Association of Physicians of India in 2009. They didn't come out and say that obesity was a disease at that time, but did establish the regional and ethnic criteria for BMI and waist. But if you read the paper, they also advise treatment of obesity in the context of preventing complications. So the elements of a complication-centric approach, here's a statement: if options of diet, exercise, drug, and surgery are applied at lower levels of obesity in the Indian population, nearly 15% of the adults in India will benefit, and type 2 diabetes and cardiovascular disease could be prevented. So weight loss therapy with an eye towards preventing complications. This is in contrast to the NHLBI obesity treatment guidelines that have been around since 1998. You can see here on the left column, you have your lifestyle, pharmacotherapy, and surgery modalities of treatment, and then BMI categories across the top. You see the no and the yes, the plus signs. So you get the idea. It's really the BMI category here that is in principle and to a large degree determining indications for these different treatment modalities. So this is more of a BMI-centric approach as opposed to a complications-centric approach. And just to kind of add on to this, problems with the term obesity, you know, this is a medical diagnosis based solely on the anthropometric component, the BMI. It doesn't give you any indication about the impact of that adiposity on health. which means the complications. So there's uncertainty regarding the health implications and definition in various racial ethnic groups. And it's not an actionable term for healthcare policy since its relationship to health is obscure. And we've seen that at various consensus conferences. Plus, it's associated with a lot of stigmatization in the public domain, derogatory use in social media, engendering guilt and weight bias. You know, we at the American Association of Clinical Endocrinologists felt we needed a more precise and better term to be used in the diagnostic complex for the disease of obesity, and proposed adiposity-based chronic disease. Adiposity-based because the disease involves abnormalities in either the mass, distribution, or function of adipose tissue. And chronic disease because it's a lifelong disease associated with the complications that I spoke to you about. And its pathophysiology and natural history is consistent with the three classic phases of chronic disease prevention: primary, secondary, and tertiary. And we hope that an ICD coding system can be built around this construct to lead to a more scientifically correct and medically actionable coding system for this disease. Now, let me illustrate the complication-centric approach by telling you about one patient, Salesh, who presents complaining of fatigue and weight concerns. So his history: he's male, age 57. He's referred to you for evaluation of fatigue, and he does complain of low energy and weakness. He has hypertension, dyslipidemia, and depression. He had a stent put in a coronary artery 18 months ago, but he's free of any symptoms of angina at this point. He also offers to you that he would like to lose some weight. His further history: he's a postal service employee, divorced with 2 children. He's tried low-carb diet with initial weight loss in the past, but he regained that weight within a year. He does have a membership to a gym and tries to get there about 1 time a week. His medications are losartan and hydrochlorothiazide for hypertension, atorvastatin for cholesterol control, low-dose aspirin, and duloxetine for depression. So your evaluation shows that he has a waist circumference of 102 centimeters. He has a BMI of 32. His blood pressure is 146/88. Fasting glucose 98. His lipids are there. LDL is 106. Triglycerides 175 milligrams per deciliter. Because of his fatigue, you obtained a TSH to rule out hypothyroidism and a testosterone to rule out hypogonadism. Those values were essentially normal. His liver function tests were elevated, CBC normal, and his renal function also normal. So you put the case together and you conclude that he is complaining of fatigue, although the etiology is not quite clear at this point. He does have metabolic syndrome. His hypertension is really a suboptimal control on 2 drugs. He has elevated LFTs. You wonder whether he might have non-alcoholic fatty liver disease. His LDL cholesterol of 106 really isn't at target for somebody who has had a stent put in. So you diagnose him with obesity or adiposity-based chronic disease based on the high BMI of 32 and complications that you stage as 1, mild to moderate at this point in time. So you start Salesh on a lifestyle intervention, which is really something he's tried before: a low-carb diet with some calorie reduction, and have him get to the gym a little bit more frequently. But after 2 months, he lost 1.8 kilograms, having a hard time losing more. Blood pressure still above target. So you order an imaging study of the liver, which shows hepatic steatosis. You also suspect sleep apnea may be contributing to his fatigue. You obtain a polysomnogram, and this does show an apnea-hypopnea index value of 48, which is a severe disease. So as a result of this additional data, you alter your obesity diagnosis to obesity stage 2, severe complications. You get more aggressive now. In addition to a structured lifestyle intervention, you add a weight loss medication. But how much weight loss do you need to treat Salesh's obesity complications? Both the non-alcoholic fatty liver disease and the obstructive sleep apnea. Well, non-alcoholic fatty liver disease, we know that that's very common in patients with metabolic syndrome, maybe 80% in some studies. but only about 18% of those progress to inflammation and steatohepatitis, and a smaller number, 2%, have progressive fibrosis to the point of liver failure, and of course patients are also at risk of hepatocellular carcinoma. So the trick is to prevent this progression and to identify patients who are at risk of progressing to cirrhosis, and we don't really know how to do that well, but we do have the approaches that can get rid of hepatic steatosis, address that, and prevent this progression, including some studies with the lifestyle plus orlistat, an older study from 2006. You can see as a result of this intervention, the body weight went down from 120 to 110 kilograms. That's 8% weight loss. Liver volume by MRI significantly decreased, and liver fat by proton NMR spectroscopy, a gold standard measure, also significantly decreased. So, 8% weight loss with lifestyle and orlistat reduced steatohepatitis, or steatosis rather. Now here's another study, a randomized controlled trial assessing lifestyle-induced weight loss on NAFLD histology. So now we have liver biopsies. You see on the left, there's the control arm, no weight loss. With the lifestyle intervention, there was about a 10% weight loss. And it was felt on the NASH activity score, the histology, which assessed steatosis, lobular inflammation, and hepatocyte ballooning, that you needed an improvement in 3 points to have a clinically significant improvement. And on the right, you can see the percent weight loss versus the change in the NASH activity score. And the circle is around those individuals who improve by 3 points or more, a clinically significant improvement, and they lost 10% or more body weight. So it's beginning to look like if you're going to address these measures of inflammation and fibrosis and more severe hepatocellular injury, you need 10% weight loss or more. We see this after gastric bypass. Here's 18 months after Roux-en-Y, weight loss of 50 kilograms. You can see that steatosis was present in 90% of these patients, reduced to 3% after surgery. Hepatocellular ballooning went down to nothing, and central lobular fibrosis was cut in half. You see on the right histological pictures before on top and after surgery on the bottom. So this 50 kilogram weight loss markedly improved the histological picture. Here's another study, Roux-en-Y surgery. BMI reduced from 47 to 29. That's with weight reduced from 130 to 80 kilograms, another 50 kilogram weight loss. Looking at histological criteria, steatosis, lobular inflammation, and lobular fibrosis. The black bars represent what was there pre-operatively, and the white bars, which there's not too many of, indicate what was found by histology in that patient after surgery. You can see that steatosis, only one patient after surgery had steatosis, lobular inflammation in only 2 of 19 patients, and lobular fibrosis in only 6 of 19 patients. So pretty good histological improvement. So for this reason, if we look at the ACE guidelines, these recommendations pertain to weight loss therapy and non-alcoholic fatty liver disease. Patients with overweight or obesity and non-alcoholic fatty liver disease should be managed with lifestyle, including calorie restriction and physical activity, targeting 4 to 10% weight loss, a range over which there's dose-dependent beneficial effects on steatosis. Weight loss as high as 10 to 40% may be required to decrease hepatic inflammation, hepatocellular injury, and fibrosis. And I think the best data we were in the literature involve orlistat, liraglutide, and bariatric surgery. So if you look at the preferred medicine hierarchy, most of the data with medicines exists for liraglutide, even though it's 1.8 milligrams a day, not the 3 milligrams a day approved for weight loss. And orlistat, maybe second choice, improvement in most of the studies showed improvements in transaminases. The other obesity drugs there's insufficient data, but I think we could expect some improvement based on the associated weight loss. All right, what about sleep apnea? Celeste had sleep apnea. I think this is under-recognized complication in obesity. It can produce a lot of problems. It exacerbates psychological and behavioral problems, causing fatigue, depression, which Celeste has, decreased libido, auto accidents. It also worsens cardiovascular risk factors, which Celeste has, leading to MI, hypertension, etc. It also has metabolic consequences, metabolic syndrome, which we also see in Celeste. We grade the severity of obstructive sleep apnea with the apnea-hypopnea index. Less than 5 is no disease, 5 to 14 is mild, 15 to 29 moderate, and greater than 30 severe. So this is just to help you interpret the data from a couple of studies. We know from the Sleep Ahead study, which was an offshoot of the Look Ahead study, they took patients with diabetes and obesity and just did sleep studies on them, whether they had symptoms or not. And only 13% of these patients did not have sleep apnea. The other 87% did. It's almost like you don't even have to do the test, just assume that sleep apnea is present. It was mild in 33% of the patients, moderate in another 30%, and severe in 22.6% of the patients. So very common problem in patients with obesity and patients with obesity and type 2 diabetes. But how much weight loss do we need to improve this? Well, here's results from that Sleep Ahead study. On the left, you see the purple bars. The one is the weight. This is greater than a 10% weight loss compared to placebo in red. And the apnea-hypopnea index, which is events per hour, we see a significant improvement in the weight loss arm of the study. On the right, you see the change in the apnea-hypopnea index as a function of weight loss category. Thank you very much. And you see that 5 to 10%, a loss of 5 to 9 kilograms, which is about 5 to 10% in these patients, was not significant improvement. You really needed to lose more than 10 kilograms or 10% loss of body weight to see significant improvement in the apnea-hypopnea index. Here's another study with medicine-assisted weight loss, this time phentermine topiramate extended release. All patients in this randomized trial were treated with lifestyle, then randomized to placebo or drug. The baseline data here shows that these patients had pretty severe sleep apnea. The apnea-hypopnea index was about 45 in both the groups. And here's what was found at baseline, at week 8 into the study, and at week 28 into the study. The white bars on the left are placebo. The black bars are treated with the weight loss medication. You can see progressive improvements in the apnea-hypopnea index. On the right, you see the change in body weight. So a 5.6% loss of body weight at week 8 did lead to some improvements. Maximum benefits were seen in the greater than 10% weight loss group in this study. So this led to this recommendation in the ACE guidelines. Patients with overweight or obesity and obstructive sleep apnea should be treated with weight loss therapy, including lifestyle interventions and additional modalities that needed. The best data existed with phentermine topiramate or bariatric surgery, but the weight loss goal needs to be at least 7 to 10, 11% or more to get predictable improvements in the apnea-hypopnea index. So our preferred medication here is phentermine topiramate. Liraglutide 3 milligrams, there was a study showing more moderate improvements. The other medications, insufficient data, but again, some improvement would be expected based on the weight loss. So let me summarize here about some principles of complication-centric approach to the treatment of obesity as a disease. It's consistent with the natural history of obesity as a chronic disease, analogous to other chronic diseases such as diabetes and hypertension. I mean, think about it. In diabetes, we control the hemoglobin A1C. In hypertension, we control the blood pressure, not as an end to itself, but to prevent the complications of those diseases. Same thing with obesity. We treat with weight loss therapy to prevent and treat complications. This approach emphasizes that the goal of therapy is to improve the health of the patient and the quality of life through treatment of complications. It provides a framework for disease stratification and also a guide for choosing treatment modality and the intensity of that treatment based on disease stage. and it assists treatment decisions in bringing more intensive interventions to those who will most benefit from the intervention, and this increases the benefit-risk ratio and the cost effectiveness. And other talks at this meeting, I'll be talking about the ACE guidelines in more detail, and some more information about pharmacology, particularly weight loss therapy in prediabetes and diabetes. So thank you very much for your attention.